Welcome back, Accelerator States, to our 6th learning track session. We're looking at the July-September learning track as a mini-series. In July, we discussed strategies to build provider capacity. And today, our focus on payment models and reimbursement. And in September, we'll look at working effectively with managed care entities to deliver housing-related services. Next slide. As a reminder, please rename your Zoom square so it shows your name and your state. As in the past, we are recording all parts of today's session for note-taking purposes. Please mute your mic unless you're speaking. And today I'll say a few words to help us get grounded. And then we'll hear about North Carolina's journey and lessons learned regarding payment models and reimbursement. After some Q&A, we're changing the pace a bit by staying together in the main room for the peer-to-peer discussions. Besides giving us a proverbial 7th inning stretch, we're anticipating a really robust conversation about the many models and strategies, and we want to enable everyone to hear the many possibilities available. Next slide. As we heard during the in-person conference and throughout our time together, payment models and reimbursement strategies are complex and are not a one-size-fits-all. States are contemplating a number of challenges, such as how to set sustainable rates and include stakeholders in that process, how to operationalize a system that reduces administrative burden and ensure adequate and timely provider reimbursement. Your teams are also trying to align services and rates with the best practices of service delivery, such as Housing First, while keeping the member experience at the center of it all. States are choosing a variety of methods to do this, from standardized rates across managed care plans to fee for service to using a per member per month PMPM model. You're also partnering with organizations to help with the administrative functions such as community care hubs and third-party administrators. Over time, states may evolve their housing-related supports and services into a value-based purchasing model after the administrative delivery system for housing supports has had time to mature. There are many ways to align payment models and reimbursement with best practice service delivery approaches, and we are grateful and excited to feature North Carolina and hear how they develop their payment and reimbursement models and the lessons they've learned along the way. After the North Carolina presentation, we'll have Q&A and our peer-to-peer discussion here in the main room. As North Carolina presents, please put your questions into the chat, and I'll get to as many as possible before we broaden out the discussion to your state's experiences, challenges, and models. Next slide, please. And now let's welcome and thank our North Carolina State team member, Maria Ramirez Perez, who is the Associate Director of Healthy Opportunities for the North Carolina Department of Health and Human Services. And she's also the HSBA State Team Lead. After Maria finishes her slides, 3 of the TA coaches, Robin Wagner, Lauren Conrad, and Jordan Gully, will facilitate the Q&A with North Carolina and then the broader discussion. And with that, Maria, take it away.
Good afternoon, everyone. So I will try my best to cover a lot of information. So I really encourage folks to ask questions along the way, but jumping right in, next slide, please. Next slide, please. I'll start with a couple of context slides, and Lord knows North Carolina has used a lot of these slides frequently, so you may have already seen them, but I want to just level set on how we built the infrastructure for providing housing supports in Medicaid in North Carolina. And I want to anchor folks on the fact that we did not set up this infrastructure within kind of a bubble of Medicaid. Really, we looked at developing infrastructure across the state that would support SDOH supports in housing, food, transportation, and interpersonal violence across the board. So that included the development of an SDOH screening tool, the development of a centralized statewide closed loop referral platform and workforce, and then we embedded that infrastructure into our into Medicaid, because North Carolina, at the time that this work began, around 2017, was directed by legislature to essentially transition our Medicaid program into managed care, which we took as an opportunity to look at the ways in which we could leverage managed care in order to adjust our care management model to better address social supports as a part of whole person health. And then within that, we built the Healthy Opportunities pilots as a way to target initiatives to develop systems, financing, and evidence-based to drive further policy changes. And that's what I'll focus a lot of my attention on today, even though it is the smaller of the circles you see. Next slide, please. All right, so I will say at the top, this is looking at the healthy opportunities pilots as they currently exist. We are in the process of renewing our waiver with CMS, and there may be changes to our structure based on that. Our waiver was initially approved in 2018. We launched services across housing, food, transportation, and interpersonal violence in a rolling basis or in a phased approach beginning March of 2022. Housing services launched in in April of 2022. And these services include, it's essentially 9 services in the housing domain, including things like housing navigation, payment of first month's rent and security deposit, home remediation services, healthy home goods, and other services. And really, they're meant to, the way that North Carolina looked at it, it was a person could get referred into a housing service, but also have food or transportation needs. And so it was getting people to the service that was the greatest emergent need, and then connecting them to other supports as they may need them, and kind of really funneling everything into our care management model in order to, again, really support whole person health. There were 29 services that were authorized initially for North Carolina's Healthy Opportunities pilots. Ultimately, we launched 28. Again, 9 of those were housing services, and all of these are defined in a fee schedule, which prices and defines all of those services, and really kind of lays out what we expect in terms of minimum eligibility for those services, how they should be provided. And the overarching goal, again, we've launched services in 2022, but what we are trying to achieve through the provision of these services is, in addition to building the evidence base and building the infrastructure, it is, can we improve healthcare outcomes for Medicaid members, promote health equity, and reduce healthcare costs in the North Carolina Medicaid program? And ultimately, if we saw positive outcomes from this, how can we then embed those services into our Medicaid program overall, understanding that this is just a program that would address the needs of one part of North Carolina's population, being the Medicaid high needs population that would be eligible for these services in currently the 33 counties where these services are available. Note, we are requesting authority to expand these services statewide. Now we have completed 2 evaluations to date on the program. One was a rapid cycle assessment, and the other was an interim evaluation. This I will speak to a little bit later as well, but really began to show some of the positive value impacts for these services in terms of us being able to see a reduction in healthcare costs and improvement in healthcare outcomes for those populations that receive services compared to those that do not. And the biggest piece that I will spend most of this presentation talking about is just the ways in which we worked to build an infrastructure, in particular, an infrastructure that would support reimbursement to community-based organizations via a Medicaid managed care infrastructure in order to have sustainable partnerships and payment vehicles that would support having these high-value services integrated into Medicaid sustainably and at scale. Next slide, please. All right. On the left of the screen is a sample region, and I will say, I think one way to think of this when looking at it is every arrow is a contract structure. So there is an agreement that exists between each of these entities for the different key roles that you see on the right-hand side of the screen. So in North Carolina, our Medicaid managed care infrastructure is set up through different products. And we really put them all under the umbrella of being a prepaid health plan. So a prepaid health plan is our version of a managed care organization. There are varying products depending on populations. We won't get into that. But what these health plans are charged with doing for our Healthy Opportunities pilot work is they are charged with approving which enrollees qualify for services and which services they qualify for based on the criteria that are set up in the fee schedule I mentioned earlier. Part of why they are charged with this is because they manage a pilot budget. And so they are the ones responsible for ensuring that, folks are screened appropriately, get connected to services, and then ultimately that what we call HSOs, which are sometimes called CBOs, and ultimately just means the community organization that is delivering the service, we want to make sure that that entity gets paid and the health plan is responsible for that piece. Now, I mentioned that North Carolina really built a lot of this into our care management model. That includes organizations like advanced medical homes, care integration networks, local health departments, really local providers. A lot of times we're talking social workers on teams that are conducting these screenings and really interacting directly with members or beneficiaries to assess them for eligibility for services and to assess the service needs before they're referred to an HSO. A lot of the work that they do is really managing the coordination of pilot services alongside the clinical services that an enrollee may need and tracking that enrollee's progress over time. In North Carolina, we also created a new type of entity in the state called a network lead, which more commonly is referred to as a care hub. And this entity develops and oversees, as the name suggests, a network of CBOs referred to as HSOs in North Carolina that provide ongoing technical assistance and support to members of those networks. I will say for the reimbursement portion of this model, that technical assistance and training has been crucial for a wide range of community-based organizations to be able to participate in a program of this scale. Part of that is because in addition to the technical assistance and training, the network leads receive, track, and validate invoices from HSOs, essentially providing kind of a first stop where an HSO's invoice goes to get checked, and also to allow the network, somebody before the health plan, to work with that CBO or HSO to make sure that that invoice is appropriate. That takes some of the burden off of the health plans, which are typically entities that are very used to seeing a claim and just saying this is approved, paid, or declined, and then let the provider kind of figure out the dispute process. But since we're working with providers that have a very wide range of experiences, it was important in North Carolina to have someone that was kind of in the middle to act as a bridge to help support the CBOs in this space. And we do currently have a little over now, but 150 human service organizations or HSOs that provide these services. These are providers that are onboarded onto our MMIS. They are Medicaid providers. We did provide some simplification to the Medicaid provider onboarding process. For example, we didn't require fingerprinting, but there is still a need to have, for example, more extensive checks of background to make sure that we are not unintentionally paying someone who is restricted in any particular list from being able to receive state or federal funds. These community-based organizations, in addition to enrolling as a Medicaid provider, for the purposes of this program, would also need to submit invoices and submit for reimbursement for any services that they deliver. Those services need to be delivered in accordance with what is outlined in that fee schedule. And they also support the identification of potential enrollees and connect them to the health plan and care manager. I will say this last piece is something that we built into the infrastructure component of reimbursement later in the program, recognizing that when we first developed the Healthy Opportunities pilots, we really front-loaded it with the health plans being expected to be really proactive in their referrals. And we didn't see that. And so then we took kind of the opposite approach to provide funding to community-based organizations for them to be able to connect people with supports, and that was much more effective. Next slide, please. All right, on to the funds flows. So I hope this doesn't frighten anyone away from this approach. But in North Carolina, really what we looked at is we took on quite a bit at the state level in terms of thinking about how can we support the new types of entities that we are bringing on as Medicaid entities without over-medicalizing the work that they are doing. So that was kind of like our first priority in the design, is how do we fold these organizations into Medicaid without over-medicalizing the work that they are doing? Because part of the reason why their work is, we thought, successful is because it is not medicalized at this time. So We do distribute Healthy Opportunity Pilot funds to health plans. These are service delivery funds. So essentially our program is set up at no risk to the health plan under the 1115 waiver. This funding is provided separate from the health plan's capitation rate. It is set up essentially as a capped allocation that they have to track against or manage against over the course of the program. The health plans receive a monthly distribution based on an annual allocation that is developed with an actuarial team. Health plans also receive an administrative funding allocation, which takes into account that there is an expectation that health plans will have dedicated utilization management staff, essentially those that are checking that applications are appropriately completed, or enrollment applications are appropriately completed, and care management staff separate from their delegated care management entities that will support enrollment in the program. Additionally, this capped allocation will include funding that the health plans distribute to a care management entity, which would be something like an advanced medical home, care integration network, local health department. We essentially built an STC, a contract attachment that sets the rates. And so we tell the health plans, this is how much funding you are going to pay the care management entities based on the number of beneficiaries enrolled. And that funding flows through the health plans to the care management entities also on a monthly cadence. The department also distributes capacity building funding. That was quarterly when the program first began and essentially slowed down as to nothing as we ran through the implementation phase of the program. This was infrastructure development funding for community-based organizations and for network lead entities that, again, were new for this work and needed additional staffing and infrastructure in order to be able to provide these services to Medicaid populations. We also provide administrative funding to the network lead entities. This is separate from the capacity building funding and would carry on over the course of the program, at least as it is currently designed. The department takes on the role of really overseeing that these payments are being made to these different entities and reconciles those payments quarterly if needed. Really what if needed means is we get quarterly reports from all of these different entities. And if anything in those reports is unusual, we look at going through a reconciliation process to claw back any funding if needed. We do receive encounters, but I will acknowledge that encounters have a tendency to be on a significant delay. And so we do not rely on those as heavily as we do on reports just because of the timing constraints. Health plans, for their part, are responsible for taking the funding that they receive, again, at no risk from the department, managing against that capped allocation for services that are delivered, paying HSOs based on the invoices that those HSOs submit that are deemed appropriate. It is important to note here, the health plan is essentially pre-authorizing services. And so any invoice they receive would be for a service that has been pre-authorized and would not exceed the pre-authorized amount. And as I mentioned earlier, they would pass through the care management piece. Services, I'll get to that in a second. I already spoke to the payment of delegated care management entities. For network leads, the department pays them the capacity building funding, and we built in a requirement that at least 51% of that funding would need to go to community-based organizations for their infrastructure development. I will say what we saw from our network lead entities in North Carolina is that they far exceeded that 51%, and a significant portion of infrastructure development funds went directly into community-based organizations, especially those that were smaller. Network leads do continue to receive administrative funds, and we did initially, in our design of the program, have value-based payments, but we will begin to phase that out over the course of the next year. As I mentioned before, the network leads review invoices, and really what we're talking about there is the way we built the system is that HSOs do not submit claims. HSOs are essentially submitting an invoice to the network lead for them to review it. So it's kind of point and click and based on units. So if they provide one food box, that food box has a specific unit value, and the network lead verifies that all of the units are appropriately registered on that invoice. The health plan would then reimburse the HSO based on those invoices that are converted into a claim. So the health plan receives it as a claim, and then the HSO is paid externally. For the payment timelines, this is something that I will say we've quite frankly had challenges with because everybody wants as much time as possible. So HSOs want enough time to be able to review their invoices before they get submitted. Network leads need time to review before they submit. And then health plans want time to review before they make a payment. All of that adds up. And what we ended up with initially was actually a 120-day timeline, which was astronomical and was really, really difficult, especially for housing providers who would have to carry a pretty significant rent burden, especially if they were providing something like payment of security deposit and first month's rent, or a home remediation service where they would carry a significant burden month over month. We have since been able to cut that back. So trying to bring that down to payment within a 30 to 60-day period at most. But that is an area where we're continuing to need to fine tune. And to the question in the chat, there's not a fixed amount that is paid. It's based on the fee schedule. So every service has a different unit price for the service that is provided. The HSO would invoice based on, it's all automated at this stage, but they invoice based on the unit amount. Next slide, please. This actually gets to some of those details as well. So to kind of show folks, this is generally what our invoicing platform looks like. So really our priority was, again, acknowledging Medicaid claims processes are, I think, infamously complicated. And we wanted to be able to include providers across a really wide range of experience levels. So everyone from organizations that had 1 or 2 staff, maybe working out of a faith-based organization, to larger statewide organizations that had a CFO. So we wanted everyone across the board to have the opportunity to participate. And that meant building really a point and click invoicing system where they would, based on the service type, they would essentially point and click how many units were completed, and then the system would calculate how much they would be able to invoice for that period of time. Most CBOs choose to invoice at the end of the month, although we do continue to encourage them to invoice as soon as possible after a service is completed. The other piece I will say is when we initially launched this program, we launched with a more manual process than we would have liked. So that means that the CBO submitted an invoice in the platform, which is referred to as NC Care 360 in North Carolina. And then within that platform, there was essentially an Excel spreadsheet that was sent to the health plans with a list of invoices. This was very manual. The health plans didn't love it. But we worked over the course of, I think it was at least 2 years, to build out an 837 transaction, which is just a claims file. So essentially the platform now ingests the invoice, processes that and transmits it to the clearinghouses as an 837. So essentially aligning the HOP invoicing process with standard medical billing structure. The one thing I will say is while we transmit N837, we do not receive back N835. I think that's something we're still considering for future iterations of the program. The other things I'll flag here is we were really looking to minimize the financial risk for HSOs and trying to ensure timely reimbursement. As I mentioned before, I think this is where we're still fine-tuning. Our initial contracting structure resulted in a longer timeline than we would have liked. And so we've had to really work on adjusting various different contracts to cut down the timelines that different entities have to review, and in order to ensure that there is sufficient time for review, but not so much that entities are actually not able to be paid timely. And the biggest consideration there is just you learn as you get information and reporting from CBOs, and so adjust accordingly. The other piece I would say is we've really worked to develop consistent standards, systems, and workflows. Part of this I've spoken to over the course of this presentation. I would say one of the more time-intensive elements has been making sure that the systems that we use are updated routinely in order to meet, to be kind of fine-tuned as we learn additional lessons from CBOs about what is most useful to them. And then as well, working to ensure security and privacy standards, recognizing that this is confidential information. Next slide, please. All right. And then I just want to do a little bit of a callback because I will say that North Carolina essentially used an existing system. So there was an existing system called NC Care 360, which allowed referrals for SDOH supports to flow in a closed loop. And we, in an effort to try to reduce the number of systems that an organization would have to use, we prioritized having one shared technology system for all pilot entities. And so we required all health plans, providers to use this system, and we required integrations across the board. This also meant that in order to have a single system, we had to build out an invoicing and an enrollment and service authorization portion of the platform in order to be able to capture the various stages or workflows for the pilots or for the program that we are implementing in North Carolina. So as you will see, there is kind of a process by which all data is ultimately going into, I'll say, all eligibility, enrollment, and invoicing data is going into NC Care 360, and then we ingest that data directly from NC Care 360 into the department in order to analyze it and to work with our evaluator to be able to evaluate that data. Next slide, please. All right. The last lessons learned I will try to leave folks with in just quick fashion is just to talk a little bit about the importance of the approach you take with implementation. I think in North Carolina, when we were first launching services, I will say initial design is always perfect. So it seems perfect when you're thinking through it. So in initial design, we were thinking, you know, what's the best way for us to launch everything in one go, all services across all CBOs, across all regions. We learned very quickly that that was not feasible. And so we began to really look and depend on working with community-based organizations via the network leads to understand what readiness looks like between different domains. And that allowed us to really get a lot of information in terms of, for us, it was the food domain was the one that had the strongest infrastructure. And so they were able to launch first, and then kind of process-wise, we're able to move across different domains. The next piece that was a big lesson learned for us was the importance of model contract development. This is something that the state took on, but I think I will say in acknowledgement that there are a lot of entities that are a part of this program and that can be a part of these types of initiatives. In North Carolina, we took the approach of developing model contracts that would exist across all of the different agreement types. So between health plan and a network lead and a CBO, we developed a model contract outlining the roles, responsibilities, and the expectations or requirements that would exist between those entities in order to try to simplify the contracting process between those entities, and also to try to take some of the burden off of community-based organizations that may be less familiar with how to be able to participate in this type of agreement, not having previously been a medical provider with Medicaid. The other important lesson learned is stakeholder engagement. And for us, this really began well before the waiver was authorized initially in 2018. For housing services in particular, there was very extensive engagement around the development of that fee schedule and the development of the design of this program. So part of what we looked at is this, you know, the fee schedule is not something that previously existed. We had to look at existing literature and also work with community-based organizations in the state and in other states to start to think through what is the appropriate way to set a unit price for these different types of services. So one of the things that was identified is that a PM payment may be appropriate for case management, but a fee-for-service approach is more appropriate for a unit price for something like a food box or a meal. Or there are fewer cases of this in housing because most of our housing services are actually set to a cap, which just means, for example, with home remediation, we provide reimbursement up to a $10,000 one-time per demonstration cap. And I will say there was a lot of engagement with the field to try to understand how to best price these different types of services, what approach is better for different types of services. I think the thing we learned is early engagement with significant training on the part of the entities that are trying to gather that feedback. Because I was talking to someone about this earlier, and they mentioned some CBOs don't know that they're a CBO. They don't think of themselves as a CBO. They're a nonprofit, or they're, you know, a local health department. They do not think of themselves as a community-based organization, let alone when we start throwing in additional acronyms like HSO. So just an organization or working with advocacy groups and technical assistance support entities that can really help facilitate that engagement is really important, and something that has allowed us to build a really comprehensive fee schedule. And I will say we continue to update it in part by soliciting feedback from community-based organizations directly and trying to make sure that they are fully informed of the type of feedback that we need in order to effectively update it. The final thing I'll flag there is a lot of times we're working with organizations that are used to a grant-based model or a HUD reimbursement model, which is different from how Medicaid thinks about reimbursement for these types of services. So again, just the importance of translating how this reimbursement is different from others that a community-based organization may be used to it cannot be overstated. This, I think, goes hand in hand with the next one, which is an investment in community-based organization participation in North Carolina. We've seen the importance of significantly investing in via infrastructure development funds, which we call capacity building funds. But this has been really crucial, in particular, in bringing on, I sometimes call them hyperlocal, but really the smaller community-based organizations that we kind of all anecdotally maybe know or have met with or have been a part of those organizations that have served their communities for decades sometimes, and just braided together different grants, have one or two staff, rely a lot on volunteers, and may not have the infrastructure that's initially needed. But those organizations are really able to support one of the goals that we had in North Carolina, which was making sure that we could invest in communities and in the resilience of communities, not just in, or thinking about health more broadly and more from a public health perspective than Medicaid, I think, has typically done. And then the last two pieces are very important. And I would say try to think of these at the top, although frequently they kind of get sandwiched together. It's like the first thing and also the last thing we think about, which is data exchange platforms and data quality. At the end of the day, the only way for us, this is a pilot, it requires evaluation. The only way for us to evaluate effectively is to make sure that we have good data that we can leverage. And so one of the ways that we approached that is by having a single platform that we could pull data from, but that still meant a significant amount of work with that vendor to make sure, with that vendor and with other partners, to make sure that the information that was going into that platform was done so in a way that was consistent. So everyone understood what all of the different fields meant. There's a lot of TA that goes into that to ensure data quality, and also a lot of there's a lot of work that goes into the back end as well, making sure that whatever goes in tracks with what you are expecting the output to read. So if we're saying enrollment, the way that people are putting in enrollment data tracks with how we are going to be reading it on the back end, essentially. And then the other piece was just making sure that data integration and data exchange platforms were something that was invested in early on. And with that, and as you're coming on screen, Robin, I've finally finished up.
No, you did a great job, Maria. Thank you so much.